We've got a few spare seats in here. If the people sitting out in the cold expanses want to come in, you might get a better view of the heads. No one's brave enough. Okay. All right. Ladies and gentlemen, welcome. My name's Nigel Parker, and for those of you who don't know me, I'm the CEO of Cystic Fibrosis WA, and I will be your MC for this evening. For those of you who do know me, it's too late, the doors are locked. Tonight represents an opportunity for some of the best CF researchers in the world to present an annual update of their work and open a window to the future of CF research here at the Telethon Kids Institute. We're very honoured this evening to have the head of the Telethon Kids Institute here to commence proceedings, Professor Jonathan Karapetis. Professor Karapetis took up the position of the Institute Director in July 2012, after 6 years leading the Menzies School of Health Research in Darwin. A medical practitioner himself and a specialist paediatrician, he is recognised as a leading mind in Australian health with particular expertise in Indigenous child health. Previous positions include terms as Director of the Centre for International Child Health at the University of Melbourne, Theme Director at the Murdoch Children's Research Institute in Melbourne, and Clinical Fellow in Paediatric Infectious Diseases at the Hospital for Sick Children in Toronto, Canada. Ladies and gentlemen, please welcome Professor Karapetis.
Thank you, Nigel. It's great to see you all here. Let me start by just acknowledging the traditional owners of this land. We're on Wajak Nyunga Budja, and it's important to know that we have the support of the local traditional owners in everything we do, and I acknowledge them and their elders. Thank you, Nigel, for that welcome. I'd like to acknowledge Richard Simons, who's the president of CFWA. Right, Richard, there you are. Hi. We've got Simon Martin, who's the acting CEO of CF Australia. There he is. Okay. And Mitch Messer, treasurer, I got that wrong, of CF Worldwide and president of CF Australia. Thank you. And of course, to welcome you, friends and particularly members of the CF community here in Western Australia, as well as the wonderful scientists who we're going to hear from today and all of their teams. Cystic fibrosis research is, we know, critical, but it's an essential part of Telethon Kids Institute, past and in the future. Indeed, we have, as part of our plans over the last couple of years that have evolved, announced AREST CF as one of our showcase projects. In other words, one of the things that we really are proud to put out there for the world as something that we back, and that also represents the right way of doing research. In other words, research that engages a whole slew of collaborators, including the community, around a really critical problem, and is focused on outcomes. And thinking about what I'd say today really got me thinking about when I started doing child health, doing paediatrics back in the 1980s, and my term on the respiratory ward at the Children's Hospital in Melbourne, where CF was a real problem. It wasn't something that you really enjoyed looking after in those days, because you all know better than I do that things have changed a lot in CF. And it's still obviously a challenging issue. We still have a long way to go. But even in those few decades, we've seen this disease transform from one where someone who has a child with CF can now be thinking of a long, healthy life for their child, with its challenges, without a doubt. But what became clear to me, and especially when I arrived here a couple of years ago, is the amazing way that the research community works closely with the broader CF community in a sort of partnership you don't see very often. So AREST CF is an incredible partnership. Yes, I will trumpet the leadership that comes out of Perth. I'll trumpet that from every hilltop I can. But it's pretty clear that it's part of a partnership that engages people, researchers and others, including the broader CF community throughout Australia and throughout the globe. And just hearing more from Steve every time I meet him about those sorts of broad collaborations and about the way that this collaboration is challenging the way we think about this disease, is really moving the whole focus of early intervention to the forefront. And Steve was just talking just a few minutes ago about how it wasn't that long ago that when he presented some of the work that is happening out of AREST CF and out of the work here in Perth, they were laughed off the stage. And that doesn't happen anymore because people realise that the work that's happening here is really leading the country and leading the globe and changing lives. So this is precisely the sort of work that an institute like the Telethon Kids Institute should be backing to the hilt, and we do. So it's fantastic to be here. I'm very much looking forward to hearing about the science, but what's great is that this is as much about the community, about the lives of children and adults living with CF as it is about the science. It's that coming together of cutting-edge technology, biology, and the reality of individuals who live with this disease. And it's about continuing to change the story so that people who live with CF can live longer and even healthier and happier lives. So with that, I'm going to hand over soon, right now in fact, to Steve Stick. Steve is a paediatrician, a respiratory paediatrician. You all know him. But what I can tell you is that he, in addition to the amazing work he does in research, the amazing stuff he does across the road, he also is a very significant leader here at the Telethon Kids Institute. Steve is a research strategy leader. He's part of our institute leadership team, and he really does assist us in setting the new directions for research here, drawing on the kind of experiences he's had that help us to change the direction of a lot of the research here. So I don't know if you need to say anything in the meantime, but maybe what I'll do is just ask you to welcome Professor Steve Stick.
Thanks, Jonathan, and welcome everyone. I'd just like to say the environment we're working in now at the Institute is a very different one from the one we were working in probably 3 or 4 years ago, where the leadership team didn't have a single clinician on it. And that's been transformed, and now there are probably nearly half the leadership team have direct contact with patients. Which I think is a fantastic change in the way that the Institute is doing business. I think Jonathan can be congratulated for encouraging that. So if I just move on, what I'm going to do in a minute is just give you a little bit of a feel for what we've been doing and the impact that we're having. And then there's going to be 3 research updates that are very relevant in terms of their impact. I'm then going to say a little bit about the future and introduce somebody who's joining the team for the next couple of years, and then also get one of our PhD students to talk about an area that until 5 years ago we really hadn't been engaged in at all, but that for the next 5 years, based on the work that she's been doing, forms a very prominent part of our research strategy. So I'll just move on. I just want to give you a bit of an overview. I'm not sure if there's there's a point here. No? Yeah, maybe. Yeah, thank you, Nigel. That's why you're the CEO. Trying to put in context what's happening. Now, for parents and patients who are here tonight, they will have been involved in our clinical programs, which starts at around 3 months when we first see children. And we do a whole heap of investigations. Lung function, bronchoalveolar lavage. We do CT scans. We collect samples from the airway, lining of the airway, and we do a number of questionnaires and quality of life measures. Now, we're doing that annually up until about the age of 5. That was our original remit. We were interested in early lung disease, but of course now, some children that were 4 back in 2005 are now 14. And so we've got data, annual data now going up to age 14 on a proportion of kids, and we've got annual data that goes on right up to there. So we've obviously got a lot of 3-month and 1-year-old children over that time period, fewer as they get older. Now, where does all that data sit? Well, it's a platform for our research, and we have 4 themes within our research: disease mechanisms, what happens in the lungs of children with CF to cause infection and the problems that we see later in life with lung disease. What are the outcomes and predictors that we can define? So can we come up with a set of outcomes that can tell us how well children are progressing? And can we predict what's going to happen later in life? We'll show the first ever evidence of a predictor at 3 months that will give some indication of what's happening at 1 year and 4 years. We're working on a whole heap of other predictors, and we're also working to try and profile children as early as possible to see what their risks are as they get older, so that we can tailor interventions in a more precise manner. It's this notion of precision medicine, and I'll have a bit more to say about that later on. We then try and look at these disease mechanisms and see if there are any interventions that we might be able to come up with that might improve outcomes. Now, when we talk about disease mechanisms, what we've realised, and what Cindy Brunt-Smith will talk about a little bit later, is that the context in which families exist, the psychosocial aspect also influences outcomes. And so the interventions aren't just drugs, it's the way we deliver care, it's the information we give parents, and all of that it comes under this remit of looking at possible interventions to make lives better for children with CF and their families, with a focus on early intervention. And then clinical trials is an issue which has been problematic. And we've been advocates for clinical trials in young kids. There haven't been any clinical trials in children under the age of 5 until we started pushing for them, and then in frustration coming up with our own trial and getting it funded from the US. And the problem has been that the regulatory authorities, so the Federal Drug Administration in the US and European Medicines Agency, in order to get a drug onto the market, have some endpoints which are used for regulation for a drug. So in order to get approved, a drug has to meet certain endpoints. Well, none of them were relevant for children under the age of 6. So it's not surprising that there weren't any clinical trials in children under 6. So we've been focusing on these outcomes and predictors, on getting some endpoints that we can use to facilitate clinical trials. We started one, Combat CF, which has been running now for a couple of years, and we'll have about another 18 months to run, which is an intervention with azithromycin from birth to prevent lung disease. And we're just negotiating on another one with hypertonic saline, which should start towards the end of the year, which is directly the result of us coming up with an endpoint using CT, which Tim Rosner will talk about a little bit later. So, facilitating clinical trials as well as running them, and influencing the agenda so that the industry will fund some studies in young kids. Otherwise, they just assume that what works in adults will work in an infant. So, how have we been travelling? Well, in 2010, we got $2.5 million for a Centre for Research Excellence. It was a 5-year project, and you can see it ends this year, and we're submitting a renewal in the next week or so for another $2.5 million, which will run for another 5 years. In itself, it doesn't run our program. It runs a fraction of what we're doing. And the important thing is that the core funding has allowed us to leverage about $12.5 million of additional funding for project owners. If I just go back, what that has enabled us to do is form these collaborations around disease mechanisms, around outcomes, around interventions with international researchers, leaders in their field, and with industry to come up with some clinical trials. So important for us, this core funding. It's not enough, but it allows us to leverage other funds. When you look at what we've done since 2004, when we got our first significant funding from the US rather than from Australia, you can see that our number of visits, annual visits that we've done with kids, so we've got images and blood and bronchoalveolar lavage fluid, is about 1,300. By the end of the decade, we'll have 2,500 visits documented. And we've got associated biobanks, that's tissue, huge data sets and images that are very valuable. And rather than being laughed off the stage 10 years ago, people are now clamouring to come and collaborate with us. So what's the impact been? Well, we've got funding back here. Since then, we've had a massive